and we're going to talk about pharmacokinetics. So on slide 24, pharmacokinetics basically describes the absorption, distribution, metabolism of a drug. So we often see this referred to as ADME. Slide 25 basically will show the what happens when a drug is administered. Basically, it gets distributed into the plasma. You may have bound drug versus free drug, and then the free drug is actually the component of the drug that actually can leave the vascular compartment and will go into the tissues, or it can go to the receptors, can be involved in or undergo metabolism or excretion. So bound drug is basically tied up to protein and is too large to leave the plasma compartment. Slide 26 describes a component which is actually a calculated component that we use in trying to calculate dosages, and this is referred to as the volume of distribution. What this is a theoretical space that basically is calculated and actually refers to the space or the compartment in which a drug distributes. So if we see a drug with a high volume of distribution, that means we have a greater or more extensive distribution into the tissues. So generally, drugs that are lipophilic have a higher volume of distribution because they can get into a number of tissues. And so volume of distribution is going to be dependent on drug penetration into the tissues, and also drugs that have protein or tissue binding will have larger volumes of distribution. Many of the drugs that you have or that you will prescribe or be familiar with will have larger volumes of distribution. Another term used pharmacokinetically is the term clearance, and this is really referring to how much drug is actually removed from a volume of plasma over a period of time. Doesn't really indicate how much drug is actually being removed, but it's really how much is being removed from a certain volume. And so we can use this as an idea of drug distribution and drug movement from one area to another. Slide 28 describes two types of pharmacokinetics. One is called a first order elimination. The other is called a zero order. Most drugs follow first order elimination or first order pharmacokinetics. And the best way to describe this is basically over a given period of time. For example, a drug that is being eliminated by first order kinetics, what we see is 10%, it's a given percentage that's being removed. So for example, we start off with a drug, and after a given period of time, what happens is it removes 10% of whatever's there. So if we started off with 10 grams over a given period of time, the next time period we would see it would have removed 10% of that, so that'd be 10 grams, or 1 gram, so we drop down to 9, or 90% of what's there. Then we take another 10% of the 90, so that would be 81%. Then another 10% of the 81, which would drop it to 72, and so forth. Zero order kinetics, we see some of the anticonvulsants like phenytoin, they have the same percentage being removed. In other words, they remove 20% each time, so you have larger changes occurring, and we have more concerns with zero order kinetics than we do with first order kinetics. Slide 29 is further defining this. Zero order is basically a constant percentage excreted per unit of time, whereas first order is basically the elimination half-life is determined by the drug concentration. In other words, we're taking a percentage of what's left. In slide 30, just need to define half-life as a term that you should be familiar with. This is often used, or an index of how long a drug duration of action is going to be. We use half-life to determine the dosing interval, and generally what half-life is it's the amount of time that it takes to reduce the drug concentration by half. So for example, if I started off with 5 milligrams of a drug and it took me 2 hours to go down to 2.5 milligrams, the half-life would be 2 hours. On the other hand, if I started off with 5, it took me 6 hours to go down, then the half-life would be 6. So what we look at is half-life often gives us an idea of dosing interval. So a drug with a long half-life, a half-life of 12 hours we're basically going to probably be dosing twice a day. A drug with a half-life of 24 will be dosing once a day. A drug with a half-life of 4 hours or 6 hours, we're probably going to be dosing 3 to 4 times a day. Slide 31 is another term in pharmacokinetics known as steady state. Literally, it means that the amount of drug that's going into the system is equivalent to the amount of drug that's leaving the body or leaving the system. So what we find is that after a certain period, we get where that the drug rate, the plateaus, and the peaks are fairly constant. The peaks are referred to as Cmax, which stands for maximum concentration. The troughs in the blood levels are referred to as C minimums, minimum concentration, and those should stay relatively constant over a period of time once you reach steady state. The time to reach steady state, generally we find drugs with shorter half-lives reach steady state quicker. It basically is going to vary with their half-life, and the rule of thumb is generally you will reach steady state in 4 to 5 half-lives. Slide 32 is showing a typical thing after a single dose. Here we see that the plasma concentration goes up. It will reach a peak and then it starts declining. The duration of the effect is going to be the period of time in which the concentration in the blood is going to be at the effective dose. So when we dose someone, we always have to go higher than what we want because we have to keep it up there for a while. And then on slide 33, similar type thing, you see that there will be a peak concentration, and one of the things that we look at for duration of how long the drug stays in the body is by looking at area under the curve, which is literally giving us a time of how much time that the plasma concentration will be within a therapeutic effect. Slide 34 is illustrating what I was talking about earlier. Here's a good example of someone taking multiple, say, oral dosages, and you see them going up to where they reach steady state, where you start seeing the plasma concentration is indicated as CP max and CP min. Those are going to stay fairly constant over a period of time, and this would be what we see after multiple doses. One thing to remember with regard to pharmacokinetics is that, and a big concern, is drug interactions. Pharmacokinetics a lot of times play a part in this. We can have drug interactions occurring because the drug it may have some altered absorption from where it's administered. For example, if it's taken orally, things that may influence the bioavailability. For example, an antacid may bind up the drug. Altered protein binding can result in a drug interaction. Drugs that are highly protein bound, which we describe as having a protein binding of 90% or greater, are subject to being displaced from the protein and the free drug concentration going up. We've talked about previously in this review about altered renal excretion. Anything that will affect renal excretion, to decrease it, will tend to cause the drug to accumulate. And then we'll talk about in just a few moments the issues associated with metabolism, where that we can either have the metabolism of the drug is inhibited, or it may be induced where we're getting a faster metabolism. Let's talk about protein binding. Slide 36. Basically, drugs that are protein bound are going to, the protein binding is going to influence distribution. It's going to also influence the rate of elimination. So drugs that are protein bound or generally have a larger drug distribution and have a slower rate of elimination. As I said on a few slides earlier, only free or unbound drug can actually leave the vascular compartment. That's the only portion that can have a pharmacological effect, and it's also the only portion of the drug that can undergo metabolism and excretion. When it's bound to the plasma protein, literally the drug and the protein complex is too big for it to move, and also the protein binding would prevent it from interacting with a receptor. Most protein binding, in fact I'm not aware of any instance in which it covalently binds, so most protein binding is reversible. meaning that another drug could come in and bounce it off, or just simply that as the drug, if no more drugs being given, that the drug will eventually release off the proteins and be eliminated. If we have extensive protein binding, generally that is described as 90% or greater, we find that the drug stays around longer, it has a longer duration of action, because these proteins sort of form a reservoir for it. But again, the higher the protein binding, the more likely we are to have a potential for drug interactions. When you talk about the proteins, as indicated on slide 38 here, albumin is probably one of the most important proteins simply because it is the most abundant protein. It generally is going to bind both acidic and basic drugs, so it binds a lot of different drugs. Our biggest concern is if a person develops hypoalbuminemia, where that they have a drop in plasma protein, which may result in more free drug. Hyperalbuminemia can occur, generally has very little effect on protein binding. We have more of a concern if there's a hypoalbuminemia. Other proteins that come into play are shown on slide 39. Lipoproteins, any drug that's lipophilic can bind to a lipoprotein. And then we have another protein called alpha-1 acid glycoprotein, primarily binds basic drugs. There's a number of psychotropic drugs that can be bound, things such as chlorpromazine, imipramine, nortriptyline, and alpha-1 acid glycoprotein concentrations can be altered in certain conditions like injury, stress, trauma, and that sort of thing. Now, the other thing that happens is that we have to take into account that there are natural or physiological barriers to drug distribution. These are noted on slide 40. One is the blood-brain barrier. We find that the blood-brain barrier has the characteristics that the capillary membrane are much less permeable. The drugs that cross the blood-brain barrier usually have to be lipophilic, most of which are drugs that you would prescribe. Generally, they have to have low ionization because a charged molecule is more difficult to cross a membrane. But we keep in mind that permeability of the blood-brain barrier can be altered in certain disease states like hypertension or things like meningitis. Nevertheless, most of the drugs that you are going to prescribe are going to get into the brain, and the blood-brain barrier is not going to be a big impediment to them, mainly because they are so lipophilic. Another barrier that we have to be aware of is the placenta. But again, most of the drugs that you will prescribe will cross the placenta. It's always a concern. And then one other thing to keep in mind is that we may also have these drugs entering into mother's milk, and therefore infants may be exposed to drugs that the mother's taking by nursing. A big component of drug pharmacokinetics and pharmacology is drug metabolism. In many cases, metabolism is the major mechanism of terminating a drug's action. The metabolism often will impact the duration of action and the intensity of drug interaction. If we were to simplify drug metabolism, and that's what I want to do, is basically what metabolism does is it generally makes the drugs less interactive, or less active, I should say, and also it tends to increase their ability to be excreted by the kidneys. So it does this by making them less active pharmacologically, and by making them more polar, that makes them more water soluble and makes it easier for them to be excreted by the kidneys. There are instances where that metabolism will generate active metabolites, and these active metabolites may contribute to the pharmacology of the parent compounds. We see this with the selective serotonin reuptake inhibitors. We do see instances where some metabolites may be really toxic. We see that with acetaminophen. And then we also have instances in which we have prodrugs, and what a prodrug does is, or what a prodrug is, where you have a parent compound that basically has little or no pharmacological activity, but gets activated into an active molecule by the metabolism. Slide 43, keep in mind that although the liver is the dominant organ for metabolism, other sites such as the lung, kidney, intestinal mucosa, the skin, and even other tissues may also play a part in drug metabolism, but clearly the liver is the dominant organ. When we talk about metabolism, one of the major enzyme systems that we use, as shown on slide 44, is the cytochrome P450 system. This is a family of isozymes. When I was coming through, we only knew about P450, but now we know about all the different isozymes. P450 has very broad substrate specificity, which means a lot of drugs are metabolized by it. The enzymes themselves are actually associated with the endoplasmic reticulum of the cell. The way these are named is basically, first of all, the P450 comes from the fact that that's the wavelength of light that is absorbed by these. But basically, when we describe these, the root starts off with CYP, and then you have a number which indicates which family of enzyme isozymes it's in. Then there's a subfamily which is indicated by an alphabet, and then there's the specific gene which has got a number. So CYP2d6 would be basically the cytochrome P2 family, subfamily D, and then the 6 would be the gene. Slide 46 is one thing to get to know about is that if you look to the left side, you will see that when you look at these different cytochrome P enzymes, that over 50% of the drugs that are metabolized are done by the cytochrome P3A system. Then you see that about another 25% is 2D6, and then the rest of it, the remainder, less than 25%, is going to be by other cytochrome P450s. On the right-hand side, what you actually see is 3A and 2D6 probably only account for a little over a fourth of the total enzyme in the liver. So 3As and 2D6 are two very important isozymes that metabolize a number of drugs. Slide 47. When we metabolize drugs, let me simplify this, and slide 47 here does a good job of it. There's two phases. There's phase 1 and phase 2. During phase 1, what happens is the drug is modified so that it has a reactive site on it. It's almost like a drop of glue, as an analogy. And this is either done by inserting a molecule or a chemical group in there that is reactive, or it takes off a group and unmasks a reactive site. So in phase 1, we expose or insert a reactive site, and then in phase 2, we glue on a large bulky molecule such as glucuronic acid, sulfate and glycine, or acetate. So what that does is it makes the molecule bulky, polar, less active pharmacologically generally. In slide 48, basically it's indicating that these conjugation reactions basically decrease the pharmacological activity for the most part and increase their excretion. Glucuronide is probably the most commonly reaction we see. That does occur in the liver, and when it occurs, then these metabolites are sent into the bile, and then the bile dumps it into the small intestine, and it is possibly subject to intrahepatic recirculation, where it can be picked up and then recirculated back through the liver. The other type of reactions that are conjugation reactions other than glucuronide, on slide 49, we have sulfate conjugation, probably the second most important reaction. Again, the metabolites are pretty highly polar, generally readily excreted in the urine. Another thing that happens with metabolism, some compounds will undergo first-pass metabolism, and what that means is the first time they pass through the liver, a large percentage of it is metabolized. So what it happens is usually we have to use larger doses, and we see a lot of individual responses and a lot of unpredictability. So we really don't like drugs that undergo first-pass metabolism. They tend to create more problems. On slide 51, what we see is there's a number of factors that can affect drug metabolism. Person's age. When you're real young, your enzymes aren't developed. When you're real old, they're worn out. Your nutritional status, for example, your protein, fatty acid intake may affect it, but two big ones to be aware of. Chronic alcohol ingestion can affect drug metabolism, and grapefruit juice. We don't like to take a number of drugs. We don't like to see them being taken with grapefruit juice. Also, we'll talk about pharmacogenetics very briefly. Just give you an overview of that in just a few moments. And the other thing is there's various comorbid conditions like liver damage or liver dysfunction, kidney dysfunction can affect drug metabolism. Slide 52 lists two other things. For example, hormones such as the estrogens and progesterone and your thyroid status can affect drug metabolism. And then we also see drugs can interact through the drug metabolism enzymes to either inhibit the metabolism or sometimes induce it and make it faster. Let's talk about enzyme induction as indicated on slide 53. Basically what happens with enzyme induction is there's an increase in enzyme activity basically due to new synthesis of enzyme. What often happens is when you increase enzyme activity, other drugs are metabolized quicker, so therefore their duration is decreased and their intensity of action is decreased. It's possible to induce specific enzymes as well as enzymes in general. One thing to keep in mind is alcohol and anticonvulsants are two groups of drugs where we often get enzyme induction. Slide 54 mentions renal excretion, another component in the pharmacokinetics. We have three major processes that are involved in renal excretion. We have glomerular filtration rate, which is basically filtering the blood. We have some drugs that can be excreted by passive diffusion. They simply sort of pass over into the tubules. And then we have a few drugs that undergo what is known as active tubular excretion, which they're using a ATPase or some other thing to actively being put into the kidneys. Where our primary concern for most drugs is glomerular filtration rate. Now I mentioned intrahepatic circulation a few moments ago, and let's take a look at it here in slide 55. So what we have is that basically the drug is absorbed. You see it coming in with the little, looks like a blue dot there. It goes into the small intestine. It's picked up by the portal vein, carried to the liver, and what happens with in the liver, it undergoes glucuronidation, leaves and goes into the bile. You can see it going down through the little green bile duct, and it's put back into the intestine, small intestine. Well, once it hits the small intestine, some of the there's glucuronidases, which are produced by bacteria, can kick off the glucuronide molecule, leaving the free drug again, which can then be picked back up and enter into the circulation and actually can be absorbed and go to the systemic circulation. And in fact, on slide 56, what you see is if we were plotting the concentration, here's what a drug would look like that underwent intrahepatic circulation. On the right, you see that you get the initial increase, it starts dropping off, and then we get this second little peak that occurs, which is where the drug has been reabsorbed into the circulation. So a drug undergoing intrahepatic recirculation can sometimes have a prolonged effect because it's broken down and recirculated again. Keep in mind, there are a number of age-related physiological changes that can affect pharmacokinetics. These I've got listed on slide 57. Things like changes in GI function. We see as you get older, you can have increased gastric pH. That can affect the ionization of the drug, can sometimes affect, break down the drug more if you've got more altered gastric pH. Sometimes the slowing, the gastric emptying will delay absorption of the drug. Sometimes keeping it in the stomach for a while will cause it to be destroyed. As you get older, the villi that that are used for absorption tend to decrease. We also get a reduction in the blood flow to the GI tract, the splanchnic blood flow, which means it can affect absorption. We also see that as you get older, lean body mass decreases. We get more fat tissue and an overall total body mass decrease. But increased adipose tissue with a lipophilic drug may distribute the drug into the lipid tissues much more than we would like. We also see plasma albumin concentrations go down. That may affect protein-bound drugs. Hepatic function, we see a decreased hepatic blood flow and overall decreased metabolism. And then I've also mentioned in the past, earlier in the presentation, about that as you get older, your renal function decreases, as indicated by decreased GFR. Now, slide 59 starts a little section on pharmacogenetics, which I'm going to cover pretty rapidly. What we talk about is polymorphisms. These are genetic alterations in drug metabolism. These are inherited. They are not dependent on pharmacokinetics, but they do influence pharmacokinetics. Slide 60, basically, we see that there are distinct subpopulations that differ in their ability to basically metabolize drugs. We've known about this for years. We've described people as poor metabolizers or fast metabolizers. And then on slide 61, I've listed a number of these polymorphisms that have been identified. What you have is the probe, which is things like Debrisoquine-Sparteine, mephenetoin, and several of these others that can be used to determine it. And we see these polymorphisms, the percentages are indicated as to 5 to 10%, for example, of Caucasians have this Debrisoquine-Sparteine. Basically, that can affect things such as antidepressants and neuropeptides, neuroleptics, and this is with 2D6. So you see on this chart basically the enzymes and the distribution in certain populations. Slide 62 basically tells us the consequence. With a poor metabolizer, generally what we find is there's an exaggerated drug response and more likely a chance for drug toxicity. The drug tends to stay around longer. We see that sometimes there's toxic metabolites that are formed. There may be some problems associated with the immune system producing immunotoxicity. But generally what we see is with poor metabolizers, more likely a exaggerated drug response. On slide 63 is what happens with ultra-rapid metabolizers, and generally we have a therapeutic failure or a poor therapeutic response because basically we metabolize the drug quicker. So we may have to use larger drug dosages. So I've given you on the next few slides some examples of these polymorphisms. So for example, in slide 64, we have antipsychotics. We see higher plasma concentrations, for example, of haloperidol. So we tend to have a greater extrapyramidal symptoms in people with having this polymorphism. We see that risperidone can be affected by these polymorphisms. On slide 65, antidepressants, we have increased plasma concentrations of some of the tricyclics, and then the ultra-rapid metabolizers basically will metabolize the drug too quickly. Opioids, basically that if you have a slow metabolizer, what will happen is that you do not convert codeine to morphine, so you have a no analgesic effect because of poor metabolism. Slide 66 just sort of emphasizes some of the issues of the clinical, or really the clinical implications. For example, poor metabolizers of 2D6 and 2C19 will tend to accumulate the drug, therefore having toxicity. Prodrugs that are activated through those systems will not be converted to the active form. And we see that sometimes that if you've got multiple drugs going through the same pathway, we may actually see these symptoms or these effects actually exaggerated even more. Just a summary again, slide 67, we see that 2D6, which metabolizes tricyclics and some of the SSRIs and antipsychotics, we see that Anglo-Americans have about 7% have this polymorphism. Latinos about 4.5%, Asians about 0.8%, African Americans about 1.9%. The 2C19s, these are some of the benzos go through that, and we see that the Asians have a greater polymorphism, about 20%, African Americans about 18.5%, Latinos and Anglos are much lower.